I'm the Collaborative Aotearoa Program Director for Healthcare Homes and Digital Platforms. That sounds like a lot of stuff. Recording has started. Leanna must have switched that on. Thank you. You see, I always forget. Because for those of you who haven't joined us, the peer group, which is what this is, we meet every third Tuesday of the month. And we're essentially kind of what it says on the tin, a group to support each other. Came from Morena Armaged, originally the healthcare home model of care and the implementation and rollout of that across the country, and the ability for us when we meet together as PHO leads, which is kind of where the leads concept comes from. Regularly, what we gain is an enrichment of sharing and collaboration, so in the spirit of that, this is what the peer groups are for. And it's why it's also, we spend a little bit of time before we go into the day and we have different speakers at different times introducing each other. So what I will do is give you an opportunity to do so. I'm just thinking, Leanna, because we haven't seen Astuti sign in yet, right? So we might, I'm not sure. Yeah, I do have a mobile number. What we'll do is we'll start the introductions and then maybe, Leanna, do you have Astuti's number? Because I'm thinking I can't facilitate and call her. Yep, can you ring her?
I'll sort that
just
out now.
See if she's all right. Thank you. Okay, so I will just go according to my screen. So Renee Morena, do you want to just briefly introduce yourself?
Kia ora koutou katoa, ko Renee aho, no Wanganui aho. My name is Renee and I am part of the Wanganui Regional Health Network and I am the Te Pae Tata coordinator. Kia ora.
Kia ora, Renee. Morena Amelia. Oh, hold on, and I've also got a phone call.
Kia ora, I'm Amelia, and I am the Healthcare Home Lead at Te Ora Campus Health in Wellington.
Thanks, Amelia. Morena Kirsty.
Morena, I'm Kirsty. I am a GP liaison in Whangarei at Te Whatu Ora. Kia ora.
Kia ora, Kirsty. Marianne, Morena.
Morena. I'm Marianne. I'm the NHH lead and GP services lead here at Te Whatu Ora, and I'm also the regional coordinator for Te Tai Tokerau, working with comprehensive care and pro-care.
Right, thanks, Marianne. Renee, Morena.
Morena koutou. My name's Renee and I'm Program Development in Marlborough, PHO.
Thanks, Renee. Morena, Olivia.
Morena koutou, ko Olivia Mador Leahy toku ingoa. I'm from Health Hawke's Bay and I'm the provider network lead and the representative coming on today. Kia ora.
Kia ora. Morena, Renee. We've done you already, haven't we, Renee? Did we do Renee?
You have.
Yeah, oh, that's right. But my screen has obviously just changed slightly. Rebecca Morena.
Morena e te whānau, ko Rebecca Taku Ingoa, ko Practice Relationship Manager Taku Mahi. So I am a Practice Relationship Manager, but also Healthcare Home Lead and the Strength and Coordinated Care Lead too.
Got just a few jobs to do there, Rebecca. Morena Petria.
Morena, ko Petria Taku Ingoa. I am co-lead for Healthcare Homes down in Wales South.
Thanks, Petria. Morena Armaged.
Morena, I'm sitting in my car this morning until I get sorted with parking. Armaged Maxwell aho. I lead out the mahi with Mel and others at Collaborative Aotearoa, and it's lovely to be here this morning.
Thanks, nice to have you, Armaged. Helen Morena.
Maria Koto, ko Helena Ho. I work at Pinnacle in a practice development capacity. Kia ora.
Nice to see you. It's a bit like when you have to play one of those games where the blocks move. Sarah Morena, good morning. I think you must be on mute.
Don't have my mic down. Morena, ko Sarah Setherley, ko Primary Health Manager Taku Mahi. Lovely to see you all this morning.
Great to see you too. Ashley, Morena.
Good morning, everyone. I'm Ashley, Healthcare Home Clinical Lead at Te Whatu Ora in Manawatu.
Nee, good morning.
Morena, it's me. I'm Nee. I'm the Healthcare Home Change Facilitator at Te Whatu Campus in Wellington.
Kia ora, Nee. I don't think we have. Are you new to the group? Welcome.
Yeah.
Yeah.
Thanks.
Esan, Morena.
Morena, my name is Eason and I'm the Sustainability Manager at Te Pae Tata.
Thanks. Helen. Hey, yes, there we go. Helen, I don't think we've said hello to you yet.
Take two, we have.
We have? Oh, very good. Okay. Rachel McCullum, I think, is the last person for me then.
Kia ora everyone, Rachel McCallum, Operations Manager here for Pegasus for our provider services, and apologies for Lovey Ritema Rapson, she's on annual leave today.
Thanks, Rachel.
Now there's two Helens, sorry.
That's all right. I think we've done both, right? Or have you haven't, that's Helen Thomas speaking, right? You haven't said just, you did, and I've got Helen read. Good, I think we've covered everyone. Is there anybody that hasn't said good morning yet or introduced themselves? No. Okay, great. So I am going to go ahead and share the slides. My one concern, actually, before I do so, is that we still haven't got Astuti online. And I did ask Leanna to try and get hold of her, but can I suggest, here's Leanna. Oh, we'll get an update then.
She's just having a tiny Teams issue. It should be 2 minutes.
Right. Okay.
I'm just
so
going
we'll
to help, but I'll come back.
Okay, so you're looking after her is the main thing, right? And we'll go on. Okay. Okay, so we've just had an opportunity to meet each other, and most people here know each other. And welcome to those who are new to the group. And as I said, the intention of this group is very much cross-sharing, so it's not us necessarily always leading. And as we go forward, and one of the things that we can talk about today and going forward is how do we support that process? So if there's particularly success stories or like good innovations, how do we share those? And always making space to talk to each other, which is kind of built into the program. We did want to kick off the year with some practical stuff, and we were interested, and obviously would love to hear from you today, where your practices are, what you think the key issues are, what the challenges are, how we can help you as always, but certainly with an update to Te Pae Tata, that's the intention as soon as Astuti comes online. And then I will also do a bit of an update around digital platforms generally, and also what stream of work. So that's today's program. And I'm just going to unshare. So have we got Astuti yet? Because what we could do is switch it up. Yeah, so I think because we don't really want to sit around wasting our time, what I'm going to do is kick off with my part of the presentation, just switch the two agenda items around. And then as soon as Astuti is with us, if I can't see the screen because I'll be presenting, then give me a shout or something. So can you all see that? That's our vision slide from Collaborative Aotearoa.
Yeah,
Am I getting thumbs
I
up?
can see
Yeah.
it. Yeah.
That's a yes. Awesome. Okay. Sorry, that's gone too quickly. So what we wanted to talk about, and we've been doing some work pre-Christmas, and this is obviously in the context of Te Pae Tata, because digital platforms is a part of that emphasis around what we can do in the early years to make a difference. So we've been thinking about that, thinking about the activity we've had to date and what else we can do to support in the context of our overall vision, which is continuing to, support health systems transformation as well as community engagement in a well-being sense. At a practical level, the work that Collaborative Aotearoa is split into 3 work streams, and it's good, just to kind of to frame it that way. We continue to support, on the one hand, adoption for new practices of the healthcare home model of care or general sustainable practice. And there are a number of practices, 200 odd, who have been using that model and using lean and using digital health for some time. So we work with those people, particularly around success stories and collaboration, and you are part of that, Mahi. And then there's the collective action component of what we do, which brings together community engagement and a wider scope than health. Today, we're really talking about the digital component. And I think what's also helpful, and Armajid said it to me yesterday, is that embedded in the model of care is digital health. And we have been using patient portals as healthcare home practices, manage my health email consultations, telephone triage are absolute, core part of the model. So has had 6 to 7 years worth of implementation and experience. And then, what else is there? And so what I did want to talk a little bit about was definitions, and then turn to the early years, what might we be doing, and also talk about challenges. The intention of this particular presentation was 20 minutes, so it's not supposed to be very long. I'm just watching my own time. And I have a message.
Mel, Astuti is here now.
Oh, yay. Okay. So just putting it to the floor for a second. Would you like me to break and let Astuti do her presentation, and then we'll come back to digital health in the context of that? Does that feel right in terms of flow? Okay, in which case that's what we're going to do. So Astuti, welcome. So sorry you had a bit of a tech issue, Morena.
Sorry, team.
Yeah, no worries. We've got a great loads of awesome healthcare home and PHO leads attending this morning. We were just kind of starting to go into the digital side of things, because I'll be talking a bit to that. But I think it makes sense to give you of Te Pae Tata and some of those core themes, give people a chance to talk about it, and then we can spend a bit more time on digital health, which is sort of 20-minute slot at the end. Does that feel good for everyone?
Sounds good. Thank you, team, and kia ora tata morena. Apologies, technology in this at this time is surprising, but obviously still issues. So I'm part of the Early Actions Primary Community and Rural Group that's been established as a program of work and attached to Te Whatu Ora, but we have a partnership with Te Aka Whaora and our Māori Pacific group as well. And I've been liaising with Amarjit and Mel around a couple of aspects of pieces of work that we are working on. And I thought we'd use today I'll just introduce you to some of the key things that we are focused on within our program of work, but then touch in a bit more detail around one of the particular programs of work and work streams, which is around comprehensive care teams, which to those working in the healthcare home space like yourselves, it will be very familiar. So I will just bring up a couple of slides. And let me just so I'm hoping everyone can see that. Sounds great. Cool. So as for those of you who have read Te Pae Tata end to end, which will be many of you, or if not, you've probably gone through and had a quick look through, you know, what are the key aspects in relation to primary, community and rural, which is the area you are focused on. You'll know that there are 4 key foundations that Te Pae Tata talks to. And this is stuff that you will have been living and breathing already in your work. And I guess it is really, really good to see that this is a platform on which the rest of the health reform, I guess for at least for the interim period, is presenting itself on. So the Te Pae Tata foundations talk about tiriti, embedding that, looking at equity, having a view on sustainability, and also very importantly, population health, which is again things that you, within a primary healthcare practice and healthcare home will be very familiar with. The Te Pae Tata also talks about the role of a strengthened primary community care sector. And I guess this is the frame that underpins our work in the early actions program of work, but will be underpinning the work that you're doing now and the work that you'll be doing going into the future, whether it's your wider PHO work or whether it is your healthcare helm detail work. In addition to, I guess, a broad approach to a focus in this areas, Te Pae Tata also talks to specific things that we have picked up in our work program and early actions on a national level. So it talks about barriers to care. It talks about the need for integrated care pathways. It talks about the role that primary, community, and rural can have on unscheduled and planned care. It talks about the role of network support services. So it's very, I guess, touches base with a lot of the primary health organisation work. And it talks about the need to adjust and look at and review the way that we fund primary, community, rural, and also looks to call for prototypes for hospital avoidance, early discharge, and home-based care. Again, these are things that are in the system already, and I guess through the Te Pae Tata process and through early actions, we're hoping to support them on a national level. So our early actions program, it was started in late July, early August. The view is that we are a very small group of people being brought together from across the motu to help sort of kickstart some of those pieces of work that have a focus on primary, community, rural within Te Pae Tata. We have 5 work streams. One is around extended community care, which is kind of the POAC. One is around health pathways. One is around the comprehensive care, which is the one that I thought we'll talk through a bit more detail today. The other one's data, digital, and telehealth, which Mel will talk to you a bit later. And the other one is around the funding accountability. As I mentioned, the way we are running each of these work streams is a co-leadership process and co-partnership process with Te Whatu Ora and our Pacific team as well. So I guess you will know all of this in terms of who our people are and where they are at. And I guess I just did want to ground us in the fact that even for our early actions, this is one of our focuses as well. We're looking to have some support around a national approach to some of the planning. We really are looking to think about where are the people and who are the providers in the community. And that's a context in which we're doing all of our work.
Astuti, I'm not sure if anybody else has got this, but I'm not seeing slides. I'm just seeing, how's everyone else on this?
Just seeing the first page.
Yeah.
Oh, is it not moving? Sorry,
No,
team.
I thought I'd call it out.
It's beautifully running on my system.
Oh.
Let me stop sharing and reshare if I can. Thanks for calling that out there, Mel.
That's okay.
Technology is not our friend today.
Yay.
Are you seeing a slide that says comprehensive primary community care?
Yep.
All right, team. Well, hopefully most of that other stuff made sense, but I'm happy to send you the slides after. Are they changing now as I change?
They're perfect now. Thank you.
Okay. Okay. Sorry, team. All right. So as I was saying, making sure that people in place, and our providers and partners are, I guess, the focus is something that's embedding our early actions program. One of the work streams, which I thought would be right up your alley and something that would be good to get some discussion and feedback on, is around the work stream around comprehensive primary community care teams. So the focus of this work stream is to support, I guess, a nationwide approach to how we could implement this model. It's very similar to from some of my previous knowledge around healthcare homework, around, building on the existing primary community care teams, strengthening them with new skills and new workforces, and I guess a systematic way across the country. We are looking to, and while I say systematically across the country, we also looking to ensure that we do look at prioritising Māori, Pacific and rural communities, and where we would go first with, I guess, resourcing and supporting these comprehensive care teams. Not that we don't think the whole population wouldn't benefit from it, but they're within the resource available, we know that we need to go targeted approach first. We also, in terms of the role of the comprehensive care teams, we'll talk through the attributes and the requirements later, but I guess in general, we want to make support, I guess, improved access and improve capacity and capability so that we can provide intensified support for the people who do actually need it. So we, again, from a targeting of these teams, we are looking to make sure that they look at those priority populations and those priority people in whānau. The way we've been doing the planning at a national level, there are been particular roles that were identified in, I guess, the work that underpinned the request for the funding that will be supporting this rollout. But we also being very clear that while we may have modelled the work on a particular way, and while there might be particular roles that there is more, I guess, examples of them working in practice, we would be really open to, at a local level, being really flexible to what those primary and community care teams would think would support them best. So there's real flexibility in the type of role that we're looking to implement based on what is that local practice and that local population's needs. In addition to providing, I guess, proactive care and preventative care, part of the comprehensive care team focuses also on admission avoidance and early discharge. So I guess making a contribution to the whole system as well as primary, community and rural. I'm hoping we flicked onto a new slide. And this is where, I guess, just really briefly, a real overview about the process that we've been going through in terms of looking at the national approach to this. So as I mentioned, their particular roles. So in the modelling work we've done, we've looked at physios, pharmacists, kaya whina and clinical care coordinator, particularly into the sizing of the actual FTE costs. But obviously we have, as I mentioned, we're being very broad, and the team have been doing a lot of engagement around roles such as extended care paramedics. They're looking at variations around the various nursing roles and other healthcare assistants as well. So again, we want to be very flexible in terms of what actually gets implemented, but we needed a way to actually size and cost the investment. We also, in this sense, looked at the different FTE requirements for different population groups. So try to look at, if you had a Māori Pacific deprivation concentrated primary care practice, what their needs would be versus practices that have a slightly less concentration, but still have those people within their primary care practice. So that's how we've kind of sized the roles. And then, as I mentioned, we've then looked at a way to prioritize the rollout. As we are looking to align with the pillars and the foundations of Te Pae Tata that I mentioned earlier, we are prioritising by Māori really strongly. That's our highest, I guess, prioritisation lever. We've also prioritised for Pacific in deprivation and rurality. There is an opportunity for us to look at different levers. We've looked at things like closed books. We've looked at things like ASH. But at the moment, these are the ones that we feel give us the right surrogate metrics for actually what we're looking to achieve for the population with comprehensive care teams. And also because we will remain flexible in terms of how the resource can be used at a local level, there'll be flexibility in that space as well. One of the third aspect to our planning approach is, I guess, a reflection of the prioritization approach. So this is where we have a dashboard across that shows the results of the FTE sizing and the prioritization across the country. It gives us a, I guess, sense of the results of how we have that prioritization approach has gone. So it gives us a summary of the population coverage for our priority populations, so Māori, Pacific, rural deprivation. It gives us a summary of the provider coverage in terms of our Māori Haora partners, Pacific practices, and practices in rural areas. It gives us a summary of the actual size of the FTE that we might require, so that actually we can then reflect on whether that's feasible or not. So it's, I guess, our way of sense checking the inputs of the FTE and then the prioritization to say, actually, does it appear sensible? And then based on that, we've gone back and tweaked inputs. And I guess it is a kind of a test and apply and then refine as we go. And then the final aspect to the national planning is actually the geospatial mapping. So I've just provided a little snippet of one of the localities that we've been looking at in particular, where based on the allocation of that modelling that I've just described, we can actually map which primary care practices in which this investment may be targeted to. And our view is that this would be a really good implementation tool for the team that would actually go and work in with the practices to say, actually, as per the allocation, this is what the investment is looking like, but what would actually work for you? And then work within that locality to say, actually, the role of the comprehensive care teams is to strengthen the primary community team, but also to work across and work with other partners and providers in that area. So just gives a visual in which the, I guess, change management support will be able to utilize. So that's sort of the base comprehensive care team sort of planning in terms of the size of the teams and where and how. The other thing, aspect to the comprehensive care teams is also looking at other roles that, and again, from some of the experiences that you'll have as healthcare home teams, this is some work that you may have done already because we know it does exist in parts of the country where you've looked to refocus some of the roles that would traditionally sit in other spaces, whether that be in other maybe NGOs. But in this case, particularly in teams that are sitting at the moment, mostly, not all, a lot in the hospital community care teams. So we're looking at particularly our district nursing teams and our community allied health teams, and looking at, which are the areas in which we could support them to be refocused to support primary community care. And as I know some teams have done it, I guess, systematically. Some places have done it in pockets. And for us, I guess it'll be working with the community to say which are the areas, and potentially it would be in some of the locality prototypes where we would be looking to support and actively support the refocus of those particular teams. So one of the things, because of the experience in this virtual room, I thought it would be good to have a conversation about is around when we're describing these comprehensive care teams. We've looked at a lot of the work that's happened around the country, including the healthcare home work and other work around, what are the key attributes of an effective and, I guess, comprehensive care team. And I guess they're listed there, but these would be really good to have some kōrero about maybe when I'm done. So in terms of our key attributes at the moment, we talk about the needs for the collective buy-in and development of, the visions that vision that will actually focus on achieving those foundation pillars of Te Pae Tata, making sure that preventative care, but also on the contribution across a system, and in particular looking at some hospital avoidance and supported discharge. Looking at leadership. So whether that be clinical leadership, change leadership, and I guess individual leadership within the team, and building and strengthening that. Ensuring that we can support people to, I guess, work top of scope. So with that comes role clarity, but also flexibility. When we've looked at the sizing of these in teams across the Motu, they are very different in terms of the sizing of them and the opportunity to potentially collaborate. Around another key attribute, which I guess talks to how people will work together, is developing that constructive team culture and connecting as a team to work and actually wrap around people and their whānau. Digital enablement, which is what I think Mel will be covering. Looking at connections across across the wider team. So, you know, partners that are sitting potentially beside us, but not within the team, but still making sure that you can partner with them to deliver, I guess, good care for people in whānau. Ensuring from clinical governance perspective, from a quality and safety perspective, we have that adequately covered, and strengthening that where there might be need, whether that's for the whole team or for particular skill sets. Making sure that there is an engagement with people and whānau in the community as teams are being established and as they continue to learn and develop. And ensuring that whatever services that the team do provide, that they're responsive, and they're obviously from an equity perspective and from cultural safety perspective, they're the right type. And this is another, I guess, piece of work that we've been working up in terms of when we would look to implement the comprehensive care teams. What are some of the requirements that we would ask of them? And they will translate some of the attributions and the I guess aspirations and intentions of the investment that was made for the space. But I guess what overall we're looking for is people from an impact perspective. You know, these teams have a really strong focus on helping people to stay well. They will support not only improved access to whether it's the range of capability and or capacity, but they will actually contribute to the outcomes that we're looking for from an equity perspective. That actually, by improving the range of skill sets that are available in the primary community setting, and by creating connections, also there will be a focus on actually how these teams will contribute and actually make an improvement on how the relationships are with primary community teams going into the future. We also hope that these comprehensive care teams will also have that focus on that preventative care, that proactive care, keeping people as well as they can, so that actually they won't actually need to tip into needing hospital care, which we know is not the right place for people to be, if possible. And I guess the final impact that we're looking for these teams to be making is actually, we know primary community care is under real pressure, and these teams will not be the answer, but they will hopefully make a contribution to actually relieving some of that pressure that primary community rural are experiencing from a capacity perspective as well. So yeah, so that's our draft thinking at the moment. We are looking to get feedback on this from key stakeholders, key groups. We're having some conversations with our executive team as well around how we could roll this out. And as the regional teams are being established as well, we'll be looking to engage with them around how it would look as if we did look to roll these out across the country. But on that note, I will stop sharing, which I'm glad that the slides did work, and really keen for any questions, but also any feedback and advice on how we approach this, because I know many of you have done this in your local programs.
Thank you so much, Astuti. I just wrote down so many notes. I have got a pile of questions, but I'm going to give our other whānau members a chance to ask some questions. Does anybody perhaps just raise your hand if you've got some questions? Anybody want to start? Am I seeing any raised hands? Shall I start? Because I've written loads down. I'll start with like a really obvious one. And I see Marianne's put her hand up. Go ahead, Marianne.
Kia ora, Astuti. I'm Marianne. I work up in the far north in Northland with general practices up here. Now, I guess I have to be the doom and gloom person. That's part of what I do here, and I have to look at the worst case scenario. We've got a lot of rurality in Northland, and we have a lot of displaced population living in very rural areas who are not enrolled with GPs. What is the process around engaging with that community? Because we've got NGOs out there, we've got primary care who are well connected, but they're still not engaging. And what happens is they turn up into hospital without a GP. So what's the planning around these comprehensive care teams and engaging with our most vulnerable population?
Yeah, so within the comprehensive care teams, the focus would be around primarily working in with the existing primary community rural teams and the population they've engaged. What we really want to do is make sure that they're informed and linked in with the whichever locality work is getting underway. And it is that locality work that would be much stronger in terms of engaging that wider community and actually connecting them into the health teams and the other community providers to actually get the care that they need. So you're right, they are a group that actually aren't receiving the care on a regular basis or on any basis apart from periodic escalation where they need hospital. So I guess the comprehensive care team's contribution to that would be around providing some capability and capacity and skills to, provide the care for them, but that would be once they would be engaged with the system. And actually, it would be through that locality work that actually we would be looking to support engagement with providers. And whether that be a primary care team or an NGO as well, that's to be determined. Another work stream in the space in our early actions program is looking at network support service and what that would look like going into the future. And the role of that would be looking around the way that people engage with primary health care in the community. And it probably will be much broader than actually just your current, general practice enrollment process. It could be that you have a much more broad approach to, either enrollment, even that is the way going forward, or at least that engagement with people in the community. So Marianne, the comprehensive care teams will have a role, but actually it'll require, change in the other aspects in the primary community care setting to actually get, support those people supported and engaged. This is certainly not the silver bullet for that issue.
So the other question I have is around workforce, and you're saying that there's like multiple levels of workforce that are looking at coming into these teams. Where are you getting them from?
So it'll depend on the particular type of workforce. So one example would be around the kaya whina role. So that's one of the roles we're looking at. And in that space, for instance, talking to them, talking to the Te Whatu team and the Pacific Directorate, a lot of these skill sets will be in the community or in this case, just in the place we're at as a health system, perhaps might be even sitting within some of those COVID hubs, for instance. So we're hoping to, repurpose and redirect some of that role, those people into those roles. And also where possible, support them to learn as they work, if they need to be supported in terms of workforce development. For the other workforces, for instance, we're looking at pharmacists. And for that, we've done a bit of a scan around, who are those pharmacists who are already working in a integrated way, who are those pharmacists who've done some of the postgraduate that would enable them to do this, and who are the pharmacists who are just interested in if we put them into a placement, they could be supported and be on their journey to be upskilled to the level that you might need in a comprehensive care team. So it's a bit of a mixed model. but there's workforce shortages everywhere, which is, I assume, why you've asked the question. And we're very aware that there are that risk that if we look to pull some of the workforces, and the pharmacist is one particular that we don't want to be pulling from the hospitals or from other settings who need them as well. So that was another feasibility thing in terms of checking that whether this is possible. And it could be that even though a primary community team would like one particular skill set, it may not be available immediately. So we'll have to just be flexible around that.
Thanks, Astuti.
Thanks, Mary.
Thank you. Anybody else with questions? Astuti, I thought I'd ask, so it sounds like there is more funding for extra roles. It's like a really basic question, but is that right?
Yeah, so the budget appropriation, which is all publicly available, so it's all fine.
Yeah.
So it is. So one of the actions within Te Pae Tata was the implementation of comprehensive care teams across the motu. And while I say across the motu, it'll be across part of the motu because of the prioritisation required. But yes, the area will be a resource that we'd be looking to implement to enable primary community care teams to employ, more skill sets.
Okay, and if one was a general practice, because a lot of us have a kind of, looking after general practice hat, and let's say a general practice is a healthcare home and they've got a comprehensive care team and they've been doing multidisciplinary team meetings in, maybe with their hip and their connect with a comprehensive team that are kind of sitting in the community. Is that right?
Some of them will be extensions. Some of them will be the first time they will have thought to even employ somebody who's not a doctor or a nurse.
And so it would be general practice employing these roles.
Well,
is that the thinking?
At the moment, the thinking it might be a mixed model.
Yeah.
So from a equity perspective, Te Whatu Ora and the Pacific team are really keen to ensure that their partners really take a lead on particularly the kaiawhina roles. So it could be likely that our Māori Haora partners, who include some practices but some non-practices, and Te Whatu Ora are really keen to ensure that they are supported to employ the kaiawhina, which is your question. They would be obviously still have the same CPCT requirements, the same aspirations of connecting and purpose to do comprehensive care team work. There'll be some roles that you're right, Mel, would just get employed directly through a general practice. But there also might be some instances where the roles may best sit with a network that sits across a number of practices. And in particular, when we've looked at the outputs of this implementation in a rural sector, because there tend to be really small practices, you'll get a spread of those sort of FTE in, part FTEs. And actually for that setting, it might make sense to have one person, one network, which might be the PHO, might be one of the providers within that area to actually employ the person to work across a series of practices. So it's probably going to be a bit of a mixed approach. And that's something that we need to detail in working with the regional commissioners as well as, the primary healthcare teams.
Yeah, because it's meant to be the next 2 years, right? These are the early actions. And certainly if I was sitting in primary care, I would be saying, okay, so how fast can I do this? And a good example, I can think of practices who have looked to they've employed nurses who came from the hospital who were qualified NASC assessors, but then DHB would not recognize that qualification and still insisted on doing all the NASC assessments centrally where there was a long bottleneck. So for example, being able to have a NASC assessor inside a practice would be, overnight revolutionary, because you wouldn't be waiting for 6 weeks for an assessment.
Yeah.
How easily can we do that sort of thing? I could see Marianne going,
Yeah, so I guess that would be about the funding flowing to that particular practice. If they have a priority sort of population, them coming up with a plan around from a comprehensive care team, this is how their teams are placed, and this is the particular role that that particular person would bring. It'd be about assessment and clinical care coordination, I'm thinking, and actually how does that fit in with the team, and then off we go and grab them in and make a plan.
You'd work with your Te Whatu Ora local arm.
Yes.
Yeah.
Yeah.
Right.
Yeah. At the moment, I mean, because in the future, it will probably that there'll be much more work with the localities, but as there's only 12 sort of prototypes at the moment, we're thinking again, it'll be a bit of a mixed model where there's those locality, a bit of infrastructure standing up, you'd link in closer to that, but where that's not, we will use existing infrastructure to actually implement.
Right. Okay.
Can I ask now?
I'll go for it, Armitage.
Yeah. So is there like the process for accessing that funding? Will it be via like RFP, or is it targeting? Is some of that funding basically rolling out now?
No, it's not rolling out now. We're just going through, I guess, putting proposals up and getting them reviewed by EOT and committee. It won't be unlike, and because of that, I can't say what the definitive process would be. But I guess the process that we are recommending at the moment is because we've gone through a process of prioritizing by our Māori Pacific rurality and deprivation. Through that process, we've identified kind of priority populations associated with the practice. So it would be almost a targeted approach. Having said that, even though we may prioritize them, a particular primary care community may not be ready for that. And if that's the case, obviously there'll be flexibility in actually bringing somebody else on that journey as well. So, yeah.
Yeah. Anything more to say about that, Armitage? Just checking
No,
because I
that's
want to
all
say
good.
something.
Yeah. Yeah. No, you go for it. Yeah.
Sorry
yeah.
to grill you, Astuti. We're doing it on behalf of all our lovely colleagues, but I do find myself thinking, okay, then, what if you're a region, and I'll put my Northland hat on, that maybe there isn't a locality other than in the far north, and you know, we do have priority populations, but we don't know whether that's in your list or not. Could, you know, how do we, whoever we might be, it might be a community group, it might be primary care, it might be a network services together with primary care. How do we put forward a business case, I guess, for anything that fits inside, you know, admission avoidance, integrated care teams, discharge? And maybe you can't tell us that yet, but I guess maybe a different question would be, what's your timescale in being able to come back to us to say, you know, you could do it this way?
I guess at the moment for this particular investment, we wouldn't be looking for business cases or proposals.
Right.
We would be looking at the moment to say actually based on the, I guess, population makeup of a particular area, you know, this is the likely investment to go there. It will then be at, I guess, that regional and then the local level to say actually, if there's any modifications to be done on that, that will be done. But we aren't at this moment looking for proposals or business cases at any point in time.
Okay, that's helpful to understand. Thank you. And so it sounds a little bit more like a kind of weighted funding formula. Something might come that says, you know, based on your demographics, there's this kind of pool. And then I hear you, there's maybe, you know, the community and those services and their readiness, etc., would respond to that in some way. Anybody want to ask any more about that? Great. And I guess maybe one final question before we move on to digital. Because I know you are, you know, have lots of history with the healthcare home journey, and how do we share learnings already to accelerate all of this?
I guess it would be just about as we are developing, we're trying to keep things reasonably high level in terms of, you know, like the attributes, the requirements, and the impacts, like, you know, I was just sharing. They're quite broad, but it would be really good to, I guess, as we are looking to implement them locally, when they get into the implementation stage, is, for instance, as those primary community care teams are developing, actually, how would your comprehensive care team function day to day? That would be really great to borrow the work you guys have done, for instance, daily stand-ups, prioritization of, a proactive risk stratification, those sort of things. Because I think, I know when I talk about comprehensive care teams, to me, it's one component of almost the healthcare home model, and it is because I know it. But there are other models that are similar, such as that were established in some of the COVID hubs, for instance, or some of the early discharge teams in some of the other pockets around the country. But yeah, no, it'd be really good to keep that going. And the other aspect that I didn't talk about today, but is also about the change support.
Exactly.
So we are looking, we know change requires change investment, and therefore that's the other aspect we're looking to implement, and that's something that's, I know, has been very strong in the success of the work that's been done to date. So that would be another place that would be good to connect and collaborate.
Thank you very much. And I see Rachel has got a hand up.
Kia ora, Astuti. Thank you for your presentation. It's actually quite exciting to see all this work being considered. Just a couple of quick questions. With the feedback that you're going to seek from the stakeholders, is that PHOs as well?
Yeah, so I've got to confirm the actual process, but we were thinking of holding some regional stakeholder groupings and some hui. So, and because our target audience is primary, community, rural, yeah, PHOs would be high on that list.
Fantastic. And just secondly, can we get a copy of your draft presentation?
Sure, no problem.
That'd be great.
Especially since you can see the first few slides, that probably would be helpful.
Thank you.
Any other questions? Okay, well, fantastic to have you with us so early on in the year. That's got us excited, exactly as Rachel says. I've got notes and notes. I think we can spend the rest of the year just working on all the things you mentioned today, which is entirely part of the journey. So it is exciting, and thank you for joining us so early in January. You're staying, are you, for the next part? Or
yeah, if that's all right, could I stay?
Yeah, of course, you're very welcome. Okay, so I am going to see if I can find my slides. Here we go. And can everyone see those okay? Great. So as we saw, digital platforms are part of the picture to support the overall context is the health reforms in a wider sense, and then in the next 2 years, some of what Astuti's been outlining. And I really didn't want to spend much more than 20 minutes, but kind of just framing that conversation for this year, because it'll be a significant part of what we do. And also reminding ourselves, what are we talking about? And I made some notes when Astuti was talking, because even this sort of attempt at a definition misses out on some further technologies, but I think it's helpful for us to think of it as more than just telehealth, and really start using language like digital platforms for healthcare, health access, health delivery, part of the health system. And these include, platforms to communicate. So that might be the telephone or the email or a messaging system, but they also include health data, patient portals, ways of monitoring data and or communicating with people, artificial intelligence that helps sort through inboxes, data that supports proactive care. There's a range of technology that helps us deliver health to the right person at the right time, and more effectively. And I've put the collective action picture there because there is a significant component, particularly in Te Pae Tata and also our own work, where we look at that opportunity and then put an equity lens over it and say, well, is this working for everyone in the community? And if you are Maori or Pacific, is it working? And quite often we know that is actually no. So how might we get it to work? And the answer lies in community engagement. It's not something that we can work through ourselves. And some of you may have seen this before, but this is a helpful way, again, to frame technology or digital platforms to support a health system. And I found some of what Astuti was talking about, being some systems thinking rather than just transactional thinking. And in this particular picture, we've got our patient or our whānau or the person sitting in a world where they may well have access to their own health information, their own care planning, their own monitoring in different forms, and that's either in forms that you're actually wearing or, for example, going to a pharmacist for blood pressure. So it may be a community-based monitoring service. And that person also may have somebody walking alongside them. So it could be a kaiawhina, it could be a health coach, it could be some kind of a key worker. So person plus information plus coach, and then able to access healthcare in multiple ways. So the walk-in, service still remains, but it is possible to, in the middle of the night in your pajamas, decide, I need to see somebody, decide who you need to see, ideally have a, choice of time, type of role, type of consultation, and then again, the actual platform for the consultation is part of that picture. And I think what's also helpful to think about is that if we think about the significant transition that's occurring in primary care from a service model that was primarily built on walking in or phoning and sitting in a building, and COVID really flipped that for us, so that's been helpful learning, to a service model where there are multiple channels coming in, there are multiple channels for consultation, and there are multiple broadening workforce roles. So that's some of what this picture talks about. And I think it's also helpful to think, so you can see technology right through it, right? But if you also think, how do we support from a system point of view, right person, right time, and also honor things like, from a patient's point of view, I only need to tell my story once. The answer is partly in process and partly in technology. And something, for example, we haven't talked about is the shared care platform, of which there are many different ones across the country. Before I go on this, does anybody want to ask anything about this particular slide, or I'll move on? Yeah, I'm just having a quick look at you all. No, you're right. I'll push on. Sorry, go back to the last slide. Okay, so yes, there it is. Inside of the plans for the next 2 years is to develop greater use of digital services to provide more care. So I want to ask Astuti some questions about that. What exactly does that mean? Access, to be able to access care, to for example, we know from research that if patients have access to their own notes, their understanding of their care and disease goes up, the medicine's adherence goes up. So one might say greater use of digital services in that instance would drive better outcomes of care. So there are many different benefits to be had. And, how do we know we're getting any better? Those are all good questions. From a Te Pae Tata point of view, I see scale. And patient portals is a journey that we've all been on for some time, and I'll refer to that in a bit. Interoperability, that's very interesting. And improving digital access, which I've talked a bit about. And what here at Collaborative Aotearoa, we had Mitch Maluli work for us for a few months, actually doing some detailed work on this. And so mihi to her in her absence. We've been doing a bit of Gemba walking and listening to, our network. And it's then thinking, okay, how do we support these aims? And I wanted to just briefly nod to particularly healthcare homes who have been using technology or digital platforms, particularly patient portals, email communication, telephone triage, and then virtual platforms, for quite some time. And then during COVID, there was a big uptake of virtual platforms in order to reduce the risk of COVID infection, so the driver was that. And then we now see largely, with some changes, but largely a drop of video as a platform, a sort of perception patients want in-person meetings, and we'll be interested to hear, more about this, and some kind of barriers, portal uptake's not kind of growing any further. Open notes is still an issue for lots of people. And I guess it would be fair to say there are pockets of good work around population health driven proactive care with MDTs and MDTs with specialists and, as Astuti said, huddles, and looking at data and starting to understand proactive care, often nursing or HIP and healthcare led. But COVID created more unplanned demand, and quite a bit of that work may have slipped. So recognizing those issues, we have formed a series of problem statements, and we'd like to do more work on this, which I won't go through one by one at this point, but it recognizes things like shared care, multiple applications, no integration, very broad definitions, lack of users and skills and so on, as problems to solve, if we look at it that way, that maybe we can help solve to support greater uptake. And on our board of work this year, we continue to promote and invest in our telehealth module, which is an education platform for general practice. There's still a lot of people going through that every month. We've just undertaken a review in terms of clinical content and usability, and we'll continue to do that. And we will do a bit more work around promotion of that again. We will be doing a digital health survey to general practice, and Armajit might want to talk a bit to this after I've presented, which will probably go out early February together with partners. And that does look to establish some up-to-date data around things like portal uptake and percentage video consultations. It's quite an in-depth survey, but would really give us a fantastic steer on what to do next. And, clearly you're an important part of that. And I just pulled up a few statistics that we looked at in 2020 and 2021. And when we do our telehealth survey coming up, we'll be able to look at those metrics relative to these. So to see what kind of change we've had in the uptake. And I know at a PHO level, quite a few of you measure this anyway, but it'd be super interesting, to see those changes. And all of this data will have an ethnicity breakdown to it. So particularly when we're talking digital platforms, if we put the equity lens over that, we may see something very different, but that then helps us target our actions. So we go into the next year with 2 key streams of work. And the other thing that I haven't talked about yet, but I will talk a bit about, particularly just before we finish this meeting today, is we also have a wānanga plan where we would like to come and work with PHOs to a general practice or service provider audience. So I'll tell you a bit more about that in a few minutes. I mentioned the telehealth modules, and the slide is there because the link is up on the top. So if you don't know about them, or of course, email myself or Liana, we can give you that link. And I don't know if any of you recently seen the College of GPs revised telehealth statement, but here's a link to that. And for a moment, I'm just going to stop sharing and see if you've got any questions. So that was kind of just a bit of a where are we and what are we planning around digital work streams. Wanted to open it up to you to maybe tell us where your pressure points are, or if you agree or disagree with some of what we've just said. And then before we close today, I will also talk a little bit about the wānanga plan. Is Armajit still with us? Oh yeah.
Yes.
Armajit, do you
yes.
want us to say something about the telehealth survey?
Only that we are still just making sure that our partners are also having that lens over it. So we've heard back from GPNZ and also Sarah Upston, and got some feedback, and you're working with Liana to tweak that, Mel. But other than that, it is, as you say, just really get that handle on where things are at out there with general practice. And we were just being very mindful of the timing, obviously, to send out. So yeah, we didn't want to get it wrong in terms of providing cause an extra burden out there. So yeah, so no, that's all good now.
Is anybody planning something similar inside their own PHO, like a survey around uptake of telehealth and or anything around digital health? No. which I mean is kind of good in a way, because on your behalf we'll be able to report back at a regional level some of that data around portal uptake and so on.
Yeah, and we will be relying on the PHOs to actually, you know, forward on to practices. That's the way we would do it in terms of, because we don't have actually direct emails to each general practice. We obviously respect the relationship with the PHOs to then forward that on. You know,
and via GPNZ, is that right? Or is our main route just heads up to our leads?
Heads up through PHOs.
Yeah.
Through PHOs, yes. Yes, and GPNZ are the same. They work in respect through the PHO in terms of, you know, your member base.
Okay, right. Heads up. Right. So, and because it's a few pages, the actions on my and Leanna's side is we're meeting tomorrow, making some changes. We'll go through a final yes with stakeholders, and then we plan to get it out to these leads, what, inside the next 2 weeks, something like that?
Yes, we talked about before the end of January. So yes, that would be the next 2 weeks, yeah.
Is that okay, lovely leads? Yeah, you'll let us know, I'm sure. But it would be fantastic. It will give us really, you know, helpful data. And some of what we'd like to try and do is work together with you and or other people. You know, is that vendors? Is it developers? I don't know. To using the data to then help, you know, unblock the barriers. So, for example, if open notes is an issue, which it kind of looks like it from our point of view, what can we do to help? And for example, answer, I don't know, but we CoLab have been doing a little bit of kōrero with Manage My Health, and they recognize that at the moment, open notes is all or nothing in its switch off function. There's no filter, only this, and maybe if there was, it would make it, so that might be a, you know, a problem solving idea. It's a possibility. And maybe they'd be prepared to do it if they understood that most of the country would then go, oh yeah, good. So I guess that's an example of the sort of thing by taking a structured problem solving approach and data. That's kind of where we're coming from, but be really interested to hear from you. What are your plans and or thoughts around digital health and supporting general practice to use it more? Any? Marianne, yay.
Look, at the moment, we're working quite closely with Te Whatu Ora up here in Tautokoro to work together to drive out Manage My Health to patients that are actually discharging from hospital. So from their end, they are enrolling people onto Manage My Health. And from our end, we've been keeping an eye over the people that are actually, you know, not just registering, but activating their Manage My Health accounts, and what that demographic looks like and how that works. And we're working collaboratively in that space. So we've also had the odd meeting and catch up with Manage My Health themselves, and they're actually a really great group to actually touch base with. They've got lots of really good ideas, and sometimes you just have no idea. Like, I thought I was quite good in it, Mel, but actually there's things that I missed. You know, so you know, you never know everything all the time. So that's kind of what we're looking at, because we've noticed that our portal use is actually quite poor here in Northland, which is really sad considering the rurality that we've got. So we want to drive that out a bit more. And, you know, our video and phone consults is something we're trying to actually demonstrate as excellence from here at Mahitahi. We're actually supporting primary care because they've got a lack of GP workforce in Northland. And we've got 2 practices, particularly in crisis. So our GPs, our clinical directors that work for us, provide virtual consults for those practices. So it's actually demonstrating the excellence from our end as well on how well that looks. So that's what we're trying to do. Let's see what happens.
Thanks. Those are fantastic examples of actually using technology that's available today. Like, we're not waiting for something new to solve a problem that's also got an equity lens on it. So, you know, nice share. Helen.
Just adding to Marianne's kōrero, we hosted a session, a peer session for our practice managers that was led by the Manage My Health team, and talk through, because there's some amazing enhancements or changes that have happened to that portal in particular over the last little bit of time, that you don't know what you don't know in some respects. So we hosted a session for our practice managers to remind them of the benefits of what the portal can do for patients, but also them and their business. So, which was really well received by our managers. So it was just a peer session over one lunch hour.
Yeah, exactly. And Patria might comment on this, but when I spent a bit of time with Well South, they had Manage My Health come in for a kind of into general practice, sort of a workshop where general practice could say, this is my problem, and then Manage Health might. And it's, as you say, I guess what happens in general practice, and particularly during COVID, is we became very reactive, and quite a lot of technology was thrown at us that we could pick up pretty quickly. You know, you could like implement and move on. And lots of new stuff has come out for Manage My Health that I know when I was a practice manager, I had not necessarily stopped and caught up or joined those dots and gone, oh, this can solve this problem and this can, oh, okay. So it can be quite helpful. It's also sometimes a bit myth busting. You know, you think that it does this, but it actually doesn't. Olivia's got a question. I think it was to Helen.
Oh, thank you. I was just asking, whether, hi Helen, Olivia here. I was just asking whether, I missed the start of that. Did you say that you delivered that alongside Manage My Health to the practice managers?
So initially we had a internal session and found that this would be some really good knowledge to share with our practices. So then they hosted, we facilitated, but they hosted a peer group session for practice managers.
Cool. Okay, thanks for that. We meet with our practice leads every Wednesday for half an hour, and sometimes we do ask them, based on what else is happening in the country, what might be useful to them. So yeah, we could possibly do that. Thank you.
We do, and it's kind of part of what's coming next, which I'll throw a slide up for just before we close when we do so. But we have also been talking to that Manage My Health team, and they have offered to come and present to one of these peer sessions. And we thought that if we gave them a good brief as to what it is we're looking for, that could be a helpful conversation. And I think, you know, in my mind, certainly, is there something that we, Collaborative Aotearoa, can do that's also a short, easy to watch 45-minute recorded session that you can then use in general practice? Because there's the technology component and then there's the process component. So for example, sometimes GPs say, oh my gosh, I've got so many Manage My Health emails coming in, I don't have the time to do it anymore. Well, that doesn't mean don't use it. It means schedule the time. It's probably a practice manager issue, actually, you know, but it's about process as well as technology, not just technology in isolation. Okay, I am going to anything more? No. Thank you so much for your enthusiasm around the subject. And what I wanted to talk through then is the few things that are coming up next in our planning. So you may have seen in the emails that go out, and thank you, Leanna, for all your admin. Leanna does such an amazing job. There's a Leads Day, in-person Leads Day, coming up on the 24th of February in Wellington. And we have got a kind of loose plan at the moment for that. Technology is another part of it. We have a couple of speakers that I can't confirm yet, but certainly it'll be around the Te Pae Tata subjects and more on comprehensive teams and workforce and roles, which is a big part of the next few years. We've talked to you about the telehealth survey. And the other thing, which I will send out a bit of an outline as to kind of an example of what we're offering. But we have, some of you may have remembered, there used to be a kind of, it used to be called boot camp, which we think is not the greatest name, but it used to be called boot camp, where general practice or any service provider could attend a kind of in-person workshop. This was about 3 or 4 years ago, and learn about the healthcare home model of care, digital platforms, have a general chat, and perhaps, you know, meet some people who are doing some of that work already. So the Wānanga is in that spirit, a kind of educative learning, connecting platform for service providers. So for your general practice would be and other service providers would be the audience in mind. But what we thought was, and this is based on some of the work we did last year, that to get the best out of that, it would be best regionally planned, and also for our team to work with your PHO team so that you're able to follow through once that workshop has, you know, happened. And also that it was addressing the needs of your rohe. So we see it as a very collaborative Aotearoa working with the PHO to their needs in a kind of regional way. So lots of little workshops, and they may be in person, but they may be online. You might say to us, one of the things we noticed in general practice, particularly during COVID, is that we got much better at learning online, quick, short meetings, learn something, implement it. So we are, of course, entirely responsive to what you think would work. So with Leanna, we'll send out something about that, asking for you to let us know if that's something you think is interesting, and when maybe in your year. It could be any time this year. So this is why we're kind of launching it now in January. You might be interested in doing that with us. Anybody want to say anything about that here and now?
Mel, I just
Yes.
wanted to add, I think we do also have the ProSci training coming up.
Yes, thank you.
On the 22nd of Feb. Yeah, so we've got the change management virtual instructor-led program, and that's on the 22nd of Feb. So I will be sending out a wee reminder with a form that you can click on to register, but just a wee reminder about that one.
Thank you, Leanna. What would we do without you?
You're
Great
welcome.
teamwork there. Okay, so a last few minutes, if anybody wants to say anything or give us any yay or nays on some of the suggestions. Okay, well then I'm going to close with our closing karakia. Kia whakaria te tapu, kia whātia ai te ara, kia turuku whakataha ai, kia turuku whakataha ai, haumie, huie, taikie. Thank you so much, everyone. Really awesome to see so many of you. Happy New Year. We will be here and contacting you soon. Obviously, reach out if you want to talk to us before that. I've got 1 or 2 arranged meetings already. And fantastic to see you all. Thank you. Ka kite.
Thank you.
Thanks, Mel.
Are you both gonna stay on by any chance?
We can do,
Olivia.
Kia ora.
Hi, kia ora.
Yeah, of course. Or
I'll
I'll stop recording. You see how,
Oh,
or
yeah.
Leanna, can you do that?
Yep, I can do that. There we go.